So I will carry on with the next presentation, which is the diagnostic evaluation of a child with congenital corneal clouding. This presentation was actually supposed to be made by Dr. Siddharth Dikshit from LVP, but unfortunately he could not attend, and so I am presenting on his behalf. Well, prompt diagnosis of childhood glaucoma and appropriate prompt treatment can minimize the degree of visual impairment, and a child should not be labeled as having glaucoma or subjected to surgical treatment unless one is reasonably sure of the diagnosis and has excluded other conditions that mimic glaucoma. What are the aims of evaluation of a child with pediatric glaucoma? First is to confirm the diagnosis. Number two, to distinguish primary from secondary developmental glaucoma, which have management implications, like angle surgery may not be really successful if it is a secondary congenital glaucoma, like say axon-filled rigor anomaly. Then establish the baseline parameters so that we can follow up this patient, to evaluate the severity and prognosis, and then the ocular and systemic comorbidities. And very importantly, to rule out any intraocular tumor, which sometimes can mimic congenital glaucoma. The evaluation consists of an office examination, especially for visual assessment, and then examination under sedation, possible in young infants, but for very small children, we have to do examination under anesthesia, and associated investigations like USG B-scan, UBM, and CCT. In the first visit, we try to elicit a very good history, like the age of onset of the symptoms or signs, and then we have just discussed the symptoms like epiphora without discharge, photophobia, and blepharospasm. Any problems during pregnancy like congenital rubella, delivery, and perinatal events like forceps delivery, family history, and also history of consanguinity, because congenital glaucoma is known to be more common in consanguineous marriages, and developmental milestones, old photographs, and social factors for older children. Then the visual assessment. So the dazzle reflex, that is the immediate closing of the eyelids on exposure to a bright light, the fixation, and then age appropriate visual acuity. As we have discussed, examination under anesthesia is a must in most cases, and when we are relatively sure of the diagnosis of congenital glaucoma, we should try to attempt to do examination under anesthesia and surgery under the same setting. Coming to the role of various anesthetic agents on IOP, in brief, almost all anesthetic agents will tend to lower IOP, with the exception of ketamine and chloral hydrate and some benzodiazepines. The equipments that are needed for this UA are the pediatric speculum, calipers, tonometer, direct and indirect ophthalmoscope, retinoscope, and Cope's gonio lens. So these in brief are the things that we do. We measure the corneal diameter, the horizontal corneal diameter with the use of calipers, measure the intraocular pressure, preferably by Parkin's applanation tonometry, evaluate the optic disc cupping and other features of the optic disc, and evaluate the angle by gonioscopy if the corneal clarity allows us to do so. So this is a sequence of events that we do. Tonometry is the first thing that we do because it is highly influenced by the degree of anesthesia and the type of anesthetic agent. Then the corneal diameter, external examination under microscope, handheld slit lamp examination, fundus examination, gonioscopy, and then ancillary tests. If a child has corneal edema, Hub's tri, megalocornea, and increased IOP, we are almost sure that we are dealing with a child with congenital glaucoma. There are some clues that we should know, which should arouse a suspicion that it could be an acquired childhood glaucoma. For example, conjunctival congestion, cells or flare, irregular iris contour, ectropion UV, neovascularization of iris, and then some other features on B-scan, etc. Now, intraocular pressure, as we have discussed, is best measured by Goldman's applanation tonometry using a Parkin's tonometer. Tonopain and rebound tonometer are the other equipments that can be done, but they probably tend to overestimate the IOP. Ideally, we should use the same instrument on follow-up. We need a speculum and appropriate anesthetic agent, and very important, as soon as possible after initiation of inhalation anesthesia and prior to intubation, because that is when the IOP is closest to the normal. The corneal haze should be noted, how much the corneal haze is, because it is representative of severity. It's usually more in center, and whether depending on the visibility of the pupillary margin or iris details and fundus vessels, we can grade the corneal haziness. Now, corneal diameter, as we have discussed, that congenital glaucoma is unique in that it causes enlargement of the globe. So, we should measure the corneal diameter, both the horizontal as well as vertical, white to white, and as we have already discussed, it's normal 10 millimeter at birth, 11 millimeter at birth, 12 millimeter at 1 year, and 13 millimeter at any age are highly suspicious. Hubs striae, as we have discussed, are usually peripheral. Forceps and forceps injury, on the other hand, causes vertical, unilateral fold, breaks in the Descemet's membrane, and there is no associated megalocornea. The normal iris features in the congenital glaucoma child shows stromal hypoplasia, loss of crypts, and prominent vessels. These are some of the features in the iris that should arouse a suspicion of a secondary congenital glaucoma, like posterior embryotoxon and peripheral anterior synecdoche seen in Axenfeld rigor anomaly. We should also note the lens, whether there is any associated cataract. Congenital cataract as well as glaucoma should heighten the suspicion of congenital rubella syndrome, and the shape of the lens and the zonules. Coming to the fundus examination, it's done by the binocular indirect ophthalmoscopy. We should know the disc cupping as well as focal areas of rim loss, and we should also look at the general fundus to look for any choroidal hemangioma and pigmentary retinopathy. The central corneal thickness, as we all know, can influence the accuracy of Goldmann applanation tonometry. It may artifactually overestimate or underestimate the true IOP. The definitive role of pachymetry in the evaluation of childhood glaucoma, however, is uncertain. According to this collaborative glaucoma research network, the recommendation is that CCT should not be used to adjust an IOP measurement, but rather it should be taken into consideration in the overall context of congenital glaucoma. The axial length, again, absolute value may not be important, but usually decreases after surgery. An increase in axial length or sequential examination is a sensitive indicator of progression of glaucoma. In the absence of good view, UBM and B-scan can provide critical information about space-occupying lesions. Gonioscopy may be difficult prior to surgery because of the corneal haziness. It should be performed when view allows so, and it is essential when surgery fails to confirm the patency of the ostium. Now, coming to the normal and abnormal gonioscopy, in the normal newborn eye, the iris has recessed beyond the scleral spar. So, the scleral spar is visible as a whitish band. In contrast, in primary congenital glaucoma, the peripheral iris inserts through the trabecular meshwork and the scleral spar is not visualized. So, these in brief are the things that we should know during evaluation of a child with congenital glaucoma. Thank you.